Whenever you're ready.
Okay, all set. Okay, hi everyone, and welcome. I'm Andrew Strauss, Vice President of Clear, and I'm here today to introduce Dr. Mark Morningstar. All of us in our little community of Clear Institute are very dedicated scoliosis practitioners, but we're very blessed today to have somebody who really is an outstanding example of a scoliosis clinician and also a researcher. He's a combination, I think, which is very unique. I know I've done some research myself, and I know the hard work involved in it, and I'm very humbled to see somebody like Dr. Morningstar who's done over 60 peer-reviewed papers on scoliosis and spinal rehab, going from biomechanical things to neurological to biochemical, really a very wide, and helped us to deepen our understanding of all the parameters that influence scoliosis. He has a doctor of chiropractic from Palmer. He's got a PhD in health services. He's triple board certified. He directs a clinic in Michigan, which is an integrative clinic that has chiropractic and neurology, I think naturopathy. It's a patient-centered model of care that he's practicing. Now, maybe all of you don't know this, but Dr. Morningstar had an early collaboration with our founder, Dr. Dennis Wogan. And together with Gary Lawrence, they authored a paper, I think it was in 2004, scoliosis treatment using a combination of manipulative and rehabilitative therapy, a retrospective case series. And this paper helped establish the foundation of the clear techniques, bringing together spinal biomechanics, neurological retraining, and the principles of rehabilitation into a cohesive package, which today makes up the clear scoliosis protocols. He's continued to build on that foundation, and he's gone into a lot of work in biochemical and neurological factors. I've taken his online training on neurotransmitter testing and so forth. He's also a founding member of SOSORT, so it just shows you how far back his commitment to conservative scoliosis treatment really goes. I don't know exactly when SOSORT started, but I think I've been involved with them for, I don't know, maybe 10 years, so it must go back quite a while. In today's presentation, Dr. Morningstar is going to take us through a very exciting and emerging area in the treatment of scoliosis, which is this biochemical assessment. And he's going to talk to us about neurotransmitter testing and how we can integrate that into our practices. So thanks very much, Dr. Morningstar. I'll mute myself and let's go.
All right. Well, thank you for the invitation, first of all, from Dr. Strauss and Heather. And thank you for the introduction. I appreciate that very much. Unfortunately, as time goes by and you start practicing forever, the longer your introduction gets, it's time. People are trying to move on from you and putting you out to pasture, so to speak. So but I'm glad to be here. I didn't do a PowerPoint. Heather asked me before the call, but I do have all kinds of PowerPoints that I'm happy to email to people if they're interested. But this is, I think for context, I'll kind of start with a little bit of a historical background on how all of this came to be, because I think that's an important context to understand, why we look at it this way, how we go forward from here, and how all of us, no matter, what flag we fly in terms of scoliosis treatment systems, that we all can do that much more for scoliosis patients. So first off, to answer Dr. Strauss's question, SOSORT was founded in 2005. We had the initial meeting. There was an initial exploratory meeting in Barcelona in 2004. And then in 2005 is when they officially formed SOSORT as a independent entity. And then that was their first meeting. And then 2006 in Poland was the first conference they held after becoming SOSORT. So 20 years ago now, 20 odd years ago. So, but anyhow, I think from one of the things that I hope everybody walks away from this Zoom call with is the idea that I think in general, people we need to have a better, more robust definition of scoliosis. And what I mean by that, and I sort of the way I explain this to my patient base is that if I were to walk out here into my local community right now and talk to 100 people and ask them what is scoliosis, 100 out of 100 people are going to tell me it's a curvature that you can see on X-ray or something similar. And even though they're not necessarily wrong, that idea is not complete enough. And it doesn't really reflect all of the things that we know for a fact go into scoliosis, into causing a spinal curvature. So, whereas that curvature is often used or spoken about synonymously with the term scoliosis, I think we have to understand that that curvature is not representative of the condition itself, but rather it's the primary musculoskeletal symptom of a more involved process. And that curvature can't happen unless certain things allow it to happen during times of rapid growth. And so, within that context or within that definition, you'll come to understand why all of this has come about. And going all the way back, so with neurotransmitter investigation specifically, the first time I ever presented this information was actually back in 2013, I believe it was, at a SOSORT meeting in Chicago. And at that meeting is the first time I ever noticed or had published that there was a noticeable pattern of neurotransmitter imbalances or values relative to people who don't have scoliosis. Now, remember, like Dr. Strauss mentioned, I'm in an integrative medicine practice and I'm not the only practitioner here. And we've been doing a lot of functional medicine testing on all kinds of patients here for a very long time. And at some point, I started applying a lot of that same functional medicine testing to scoliosis patients in particular. And that's where then this noticeable neurotransmitter pattern came about. And at first, I was very inquisitive about it, didn't really know. It's sort of like you learn new information, but you don't necessarily know what to do with the information. And of course, the whole idea of SOSORT at the time is to help like-minded clinicians engage and discuss ideas and try to advance those ideas. Well, I remember at the time I gave my presentation, and at every abstract presentation, for those of you who have been to SOSORT, you'll know, but you get essentially like 5 minutes or so, sometimes 7 minutes, depending on how many abstracts are there. And then they usually give you 2-3 minutes after your presentation for people to ask questions. So after my presentation got done, one of the more well-known SOSORT doctors, one of the original founding members of it as well, sort of stood up and kind of asked a kind of a tongue-in-cheek question. He says, so Mark, if all of these scoliosis patients have low serotonin, how come they're not all depressed? Which, of course, the room sort of kind of chuckled, I mean, we're talking, a couple hundred people at this meeting. And the question really sort of stumped me. And at the time, my only response quite literally was, well, how do we know they're not? And of course, that was just kind of like, okay, whatever. And then you sat down. But his asking me that question set me off on a whole path of finding out exactly why I was seeing what I was seeing in this patient base. And it's what led us to present day. There's several papers later, widely expanded versions of what we first saw, all relative to scoliosis. Not only scoliosis onset potentially, but more germane, especially for today's lecture, scoliosis curve progression. And interestingly, as a side note, even though I never really published this on my own after the fact, after that meeting, what you'll find, if you look up on PubMed, going back into 2015 to 2017, you actually start to see European papers published on how kids with scoliosis are more likely to be introverted, have low mood, be socially withdrawn, uh, potential for anxiety. Well, guess what? These are all neurotransmitter symptoms. So potentially I was right. And the only thing is I didn't necessarily know how to explain it at the time. And but what's very important to understand about neurotransmitter status relative to scoliosis, of course, is that everybody sort of hears the term neurotransmitter, like serotonin as an easy example, right? And most people only consider the neuroemotional aspects of neurotransmitter status. You think of, okay, if I have low serotonin, I'm going to be depressed. If I have low melatonin, I'm not going to be able to sleep. If I have high catecholamines like norepinephrine or epinephrine, I'm going to be in fight or flight. However, one of the very interesting things, and I'll just take serotonin as an easy example, mainly because it's been one of the more well-studied ones, is that serotonin is responsible for somewhere around 80% of all of the transmission of all of our peripheral neuromotor pathways. Chief among those, of course, is torso muscle coordination and control. So, of course, if I have a problem with my serotonin status, I'm naturally going to have a problem with neuromuscular coordination, especially since, and the epitome of that is postural control. And in fact, this is actually going back a ways further. In viewing it this way, I remember a long time ago when I myself was a chiropractic student, I remember hearing and watching a lecture from Dr. Wogan. Tells you how long ago this was. Back when he was still part of the Pettibon Institute. And he had, and maybe you all have seen this, but there was a cartoon, a Charlie Brown cartoon, where Charlie is talking to Linus about how he has a slouched posture. And the reason why he has a slouched posture is because he wants to feel depressed. And his problem is if he starts to stand up straight and he improves his posture, then he starts to feel better. And he doesn't want to do that. So he maintains this slouched posture, which of course everybody sort of laughs at. Obviously, it's a funny cartoon, but the reality is our emotional status, meaning our neurotransmitter status, is intimately connected to postural control. And I mean, you just think about it, in our minds, how does a drill sergeant in the Army, for example, talk to people? I mean, what kind of posture do they assume to make you feel a certain way? And even us ourselves, when we stand up and we stay up and out, as they say in Alexander technique, for example, better posture automatically provides you with better emotional health, frankly, almost instantly. So it only makes sense as saying if these two function out, clinical observations, let's call them, outward posture and emotional status or emotional symptoms, let's say, it only makes sense that there has to be some type of common ground among those. Well, that common ground is our neurotransmitter status. And the one thing that honestly really probably grinds me more than anything is that none of this information is new. Yes, I've been working on this for 15 odd years or so, but the reality is it's been well known that neurotransmitter status is part and parcel to the progression of scoliosis at least since the mid 1980s. But yet the problem in conventional scoliosis management is you have orthopedics spearheading the management of the condition, and obviously neurotransmitter status is a little bit out of their wheelhouse because obviously, as we all know, modern medicine is very compartmentalized. So, and unfortunately, we're trying to take a very compartmentalized approach to a condition that is highly multidisciplinary. And I think the reason chiefly that it is multidisciplinary is because we have a lot of different body systems that affect neurohormone status, meaning both neurotransmitters and our sex hormones. And so that's kind of a little bit of the background on where a lot of this started from. I think the big thing in neurotransmitter status, so knowing that neurotransmitters are connected both to emotional health and to neuromotor coordination, which are, neuromotor coordination, as we all know, is one of the main sort of foundational constructs of the really the most widely adopted as of present day anyway, etiopathology models of scoliosis, which is the double neuroosseous theory, if any of you are familiar with that. And part of that theory states that you have to have a disproportionate growth, but a lot of that disproportionate growth is due to different rates of signaling among our hormones and neurotransmitters. And you have to have all of that to happen in order to develop a progressive curve. But yet, how many people ever do anything about neurotransmitter status or bother to even check it, frankly? So anyhow, so going back then, after all of this was sort of observed and published and so on, it's one thing to say, okay, so scoliosis patients seem to have weird neurotransmitter status. What does that mean? What can I do about that? And how is it impacting what we're having them do from a therapy perspective? Whether it be, a clear intensive or a boot camp or a PT intensive, whatever people are doing for their own scoliosis specific therapy. I wanted to know, does this have anything to do with the outcomes that they're getting from their therapy? And so one of the things we did, in fact, I think Heather said I can share my screen. So let me try this here. So this paper was published back in 2014, basically looking at exactly that. In other words, if somebody's neurotransmitters are off, how does that play into what their outcomes look like months later? Meaning, if somebody's in my office today doing a clear intensive and they go home and they are, even if they're essentially compliant to a very reasonable degree, what is their result going to look like 6 months later? And so that's what this paper really looked at. And what we actually find is that in the two groups, so we took two groups of scoliosis patients and essentially broke them up into one group that had the neurotransmitter testing completed and then subsequently participated and did the recommendations that were provided in effort to fix whatever neurotransmitter problems we identified. Then the other group also had the same neurotransmitter testing done, but they, for various reasons, decided not to proceed with the nutrient intake or dietary modifications, etc. And that might have been due to cost issues on their part, or maybe they just a lot of people, especially at this time period, there were a lot of people who didn't really have a big connection between why would I take supplements for scoliosis, because they're not actually fixing my scoliosis. And so that takes a lot of constant communication and reinforcement and education as to why that's important. But you also have to have some kind of data to back that up. So this was published, and what we found is that patients who took the supplements, not only were their curves far more likely to stay where they were at 6 months after their therapy, but a significant group of them also continued to improve upon the benefits 6 months later. In the group that didn't follow up with the nutrient recommendations based on their neurotransmitter findings, the majority of them still maintained their changes, but essentially the majority of them actually had regressed to within a 5-degree difference, plus or minus difference of their baseline measurements. So to us, that was enough on my perspective to say, okay, if obviously I'm going to have people do a therapy program, and these people are going to spend a lot of money to participate in this program and fly from the ends of the earth, as I know you guys have the same situation too, I obviously want to give this the best chance to work. Because if it doesn't, they're not going to blame themselves, frankly. So that's where this came into being. And this paper for me was sort of okay, obviously we know it's impacting their care. We obviously have to start doing this in everybody. And from that point forward, every single one of my patients, as a requirement, gets laboratory testing done. Now that's been expanded since a lot of this was done into other body systems and components as well. But this was really sort of the foundation of all of this. And so I think that's a really big, even if it's nothing but a historical point to say, 10, 11 years ago is really when most of this was really first really described in detail. And when at that point, also a lot of other providers, non-chiropractic providers, started picking up on the information as well. And I have MDs and DOs that provide this same type of nutrient recommendations to people now, not only in the US, but also in the UK, who are surgeons. And they look at it interestingly as well. Obviously, what this is not going to hurt the patient. And as long as the benefit outweighs the risk of the therapy, why not do it? Which, frankly, it's refreshing to hear a surgeon say that, because I'm sure that most of us have probably not heard something like that before from a surgeon. So that was, kind of a refreshing thing to hear. Now, one of the other aspects then, so it's one thing to say, does neurotransmitter status affect the outcomes of our therapy? Because obviously that's a big key, right? Well, there's another aspect here to say, what is the link between a person or a patient's neurotransmitter status and their curve progressing? And when I talk about curve progressing, I mean the potential even for curve progression, even if the patient is 100% compliant with care. And so again, and this is 2018, so a few years later, a study done to show, if I'm going to scroll down to the meat of this basically, but you'll see what we did is we took groups of patients who didn't have scoliosis, who had scoliosis, but it was not considered progressive, and a group that was considered progressive. Now, the differentiation among the two scoliosis groups is one group had progressed already at the time of neurotransmitter collection to surgery threshold, and the other group had not. And so what we wanted to do is I wanted to look at what is, or is there a difference in neurotransmitter status among these various groups of people? So as you can see, the two scoliosis groups had a much different trend for neurotransmitter status. And in all three cases, 3 of the 4 comparisons were statistically significant. And then when you look at each neurotransmitter in and of themselves, you can see down here for serotonin how much lower their serotonin level was to a non-progressive curve and then to a non-scoliotic. So we use this data to predict from the outset of care as to whether or not somebody's neurotransmitter pattern makes it look like they might progress to surgery threshold, and perhaps even despite what we're doing therapy-wise. Now, what we're doing now, because this is a kind of a paper where, again, it's a clinical study. The hard part is, and any pessimist could argue this, and you have to agree with it in a certain respect, is first and foremost, we don't know in the people who weren't 50 degrees at the time of collection, maybe they would have been 6 months later, a year later, who knows? And then that would have kicked them over into the progressive patient category. The other aspect we don't know is, was there a difference between progressive treated and progressive untreated patients, which we didn't have sample sizes of those necessarily big enough to be able to compare and produce a powerful enough response, statistically speaking. But those are all things, and unfortunately, that part of that is really kind of the bane of all conservative scoliosis research. and frankly, even in some cases, surgical research as well, in terms of long-term follow-up and things. But it's the best we have. And anything that we can do to predict how a patient might respond to our care, the better, right? Because there's one thing in my experience. I mean, I've been in practice now for what, 25 years here last month. Um, the the biggest thing that I notice is I don't care what scoliosis therapy you prefer to do. I don't care if you're doing Clear Institute. I don't care if you're doing Schroth therapy. I don't care if you're doing C's. I don't care if you're doing like my former group ScoliSmart. I don't care if you're doing a spine core brace or multiple of those, frankly. The idea is all of those different treatment systems can rightfully claim successes. And all of them have produced a track record of success for various patients. But all of them also produce failures. And that's just part of the game. You know, there's a reason, I suppose, we call it the practice of medicine. Well, to me, the goal of all of this kind of testing is really to best predict the people who are going to respond to your care, and the people that you already can deduce are probably going to, or at least have a very fair chance of failing your care. That way, that line of communication can be established from the beginning. And more importantly, now it allows you as the practitioner to be more of a case manager, in the sense of, I can now involve other people into this person's care sooner than maybe they otherwise would have sought care on their own, because maybe that person's presently only at a 29-degree curve. But yet, if I have a very significant neurotransmitter profile, it might be worth involving a VBT surgeon and bringing them into the loop, so that at least if and when the time comes, the family and that surgeon can pull the trigger at the most optimal time to get the most correction they can out of that procedure. And so the name of the game, really, frankly, is patient selection. So this paper has actually then spurred a lot of other investigations. In fact, let me pull up another one here for a second. I would suppose this one's sort of the epitome of things, and you guys might have already seen this, possibly. Share my screen again. This is a paper just from last year. And again, what's nice is that this is somebody in an entirely different part of the world collaborating. You know, it's an Asian and American combined study, also looking at neurotransmitter status. Now, a lot of you might have heard studies being generically referred to as the zebrafish studies. This is one of those studies. But again, its central mechanism is on glycine. Again, another neurotransmitter. Glycine, basically what this shows is not that the person has a glycine deficiency, but what they have is they have a lack of glycine utilization due to lack of glycine transport. And the problem with that is that when glycine becomes underutilized, glycine levels rise as a result, because it's not being used and metabolized. And when that happens, glycine starts to interfere with the ability of other neuromotor-based neurotransmitters to bind to their respective receptors, and then obviously signal for their respective processes. And so, interestingly, this glycine neurotransmission problem has a distinct genomic variant attached to it. Now, there's another whole lecture that we could do on genomic variants, probably an entire weekend on genomic variants, but many of the neurotransmitter problems that we run into have genomic predispositions for them. So, like, as an example, if I were to look at a neurotransmitter test, and I see that a person is low on serotonin. To say that somebody's serotonin is low is good. I mean, obviously, we identified a problem, but the downside of looking at serotonin by itself is that it doesn't tell you how to intervene. Meaning, if I'm low on serotonin, I'm really only low for one of a couple of reasons. And this is true for all of the neurotransmitters. So, in the sense, I'll use the analogy I always use with my patients, is that if I want to build a house, I need two basic things to build a house. I need construction workers and I need lumber. And if I'm missing either one of them or I'm missing both of them, I don't get my house. Well, it's not enough then to just take a test that says you don't have a house. Okay, I don't have a house, but I need to know why I don't have a house because that's how I fix the problem. So, for example, if I see that somebody's low on serotonin, hence they don't have a house, well, if I assume that it's because they don't have enough lumber, which is the way a lot of people approach it early on, and they say, okay, what is the lumber required to build that house? Meaning, what is the precursor required to convert to serotonin? And that precursor, of course, is 5-HTP, along the tryptophan pathway. So I could give that person 5-HTP in a supplement form and then advise them on dietary recommendations to increase their natural intake of tryptophan. But if I'm missing construction workers, I can flood that person's body with 5-HTP all I want. I'm not going to raise their serotonin very efficiently. And now I might just start backing the system up and increasing my 5-HTP and L-tryptophan stores, which then start going down the kynurenine pathway and actually becoming pro-inflammatory. So there's a way to intervene where you can help them, and there's a way to intervene where you can mess them up if you don't know how to intervene. The other aspect then, of course, is in the construction worker side of things, you can give them the construction workers, which are enzymes. Now, as easy examples, if I want to convert 5-HTP into serotonin again, I need vitamin B6, which is a methyl donor in that process. And I also need something called BH4 or tetrahydrobiopterin to make that chemical conversion. So if I'm missing one or both of those enzymes, I'm still not going to get serotonin. And as a side note, so for, again, for people who need the brush up on the biochemistry, the tryptophan pathway starts with L-tryptophan and ends with melatonin, effectively. Melatonin sort of gets converted off into kynurenic acid, but that gets a little bit lost in the weeds. So it starts with L-tryptophan, ends with melatonin. And you all might have seen this, but about, I think it was the summer of 2023, I believe, there was an article published in the journal Children, which is a Swiss medical journal, by 3 pediatric orthopedic surgeons in Romania. And what they did is they took a group of kids who were newly diagnosed with scoliosis. And what they found is that in the kids who, or all of these kids, I should say, had curves between 10 to 19 degrees. So in a stage where classically a surgeon is just going to do nothing, right? Watch and wait and watch it get worse. So they split the group into 2, and one group they continued to observe, and then the other group they actually gave them 3 specific nutrients. They gave them 600 milligrams of calcium, 2,000 international units a day of vitamin D3, and 1.5 milligrams of melatonin. And lo and behold, statistically significantly, the children who took the nutrients, their curves did not progress nearly as much or as frequently as the kids who just did nothing. Imagine that. So now you have to ask yourself, why would taking 1.5 milligrams of melatonin help? Well, again, melatonin problems have been part and parcel and attached to scoliosis for a very, very long time, just as long as it has with serotonin. But that's not surprising because they're in the same biochemical pathway. Serotonin converts into melatonin. And so, of course, if I'm low in my serotonin, I probably am running a little bit low on my melatonin. So what some people will try to do is to just supplement with melatonin, like in the case of this Romanian study. Now, that will work for a certain degree of patients. However, taking melatonin on an extended period of time, especially if this is, say, I don't know, a 9 or 10-year-old that's just getting started into care, and you're planning to see them conceivably until they're 14, 15, 16 years old, that's a long time to take 1.5 milligrams of melatonin every single day. And that comes with its own problems when you basically intentionally amp up the very downstream end product of a biochemical pathway, because now you just stagnate that entire pathway. Now, I'm not saying there aren't times to give people melatonin, because there certainly are. But to just intervene without knowing what you're doing, you may be inadvertently causing a certain amount of problem as much as you're helping. Now, you're going to help a lot of people with that, but you're also potentially going to harm some people with that too. So you just have to be careful. Now, and that's the nice thing with neurotransmitter testing, is that not only then do we get a baseline on the testing itself, but the neurotransmitter testing allows me to intervene and then retest as quickly as every 3 to 4 months to know if the treatment intervention that I've selected is actually doing what it is intended to do. And the nice thing about neurotransmitter testing is it's all done by urine collection. So it's a nice, easy, non-invasive way to gain access to neurotransmitter status. Because obviously, I'm sure you don't have to guess at how many children like to be poked and have their blood drawn. So anytime we can do a urine collection, and in most cases, you can give the patient a kit and have them collect right at home, because it's typically a first morning urine. So it's a very easy way, non-invasive way to get this, obtain this information. As far as testing itself goes, might as well segue into that. With neurotransmitter testing, there used to be, or for a while, there was some concern, I'll say, that when you're doing a urinary neurotransmitter test, you are measuring their peripheral levels of those neurotransmitters, not their central nervous system levels of those neurotransmitters. So there were some clinicians who felt like urinary neurotransmitter testing is not valid because it's a peripheral assessment, not a central assessment. Well, on the surface, that sounds like a fair idea. However, first and foremost, I don't know how many of you are keen to running a spinal tap on all of your patients to get their neurotransmitter status. I certainly am not. And B, what everybody has come to know is, and in the functional medicine space, people have known this for a very long time, is that depending on which neurotransmitter you're speaking of, anywhere from 70 to 95% of a given neurotransmitter is either produced or activated in the intestinal tract, which of course is peripheral. So if it's a peripheral mechanism by which most of our neurotransmitters are either produced or activated, then obviously peripheral testing of said neurotransmitters is equally as plausible and valid. And the nice thing is it's very reliable. Because the nice thing is it's not something where you have to wait a year to know if your treatment plan is helping. Because that's one of the big things, one of my own personal frustrations, I suppose, is that people who give their patients supplements and then there's no opportunity to retest. And I'm not picking on any one method in particular, but just as an example, there are a lot of us chiropractors who do muscle testing to determine nutrient supplementation for patients, which is fine. I'm not opposed to that. However, at some point, you need to have some type of clinical validation as to whether or not that nutrient has actually done what you needed it to do for that person. because not everybody should have to take nutrients forever and ever and ever and ever and ever. Nobody wants to take 10, 20, 30 bottles of supplements for the next 50 years of their lives. Some people do, and that's fine. But if you're really doing the things to get to the root of the problem as to why that neurotransmitter was off in the first place, you now should have the opportunity to actually solve that problem for that patient so that they don't have to stay on the nutrients, because now you've resolved the underlying reason as to why that neurotransmitter was off in the first place. And in many cases, neurotransmitter imbalances, because of the connection to the intestinal tract, intestinal problems are some of the direct origins for many neurotransmitter problems. And in fact, some of you who are research nerds like me might know that just a year ago, they published finally. So something I had always noticed myself in clinical practice for a long time, and maybe you all have as well, or some of you have, that a great many of your scoliosis patients tend to have a lot of digestive symptoms, almost reported as kind of like separate problems, right? Side issues, if you will. But the reality is they're all part and parcel to the same problem. And many times those digestive symptoms are what directly trigger neurotransmitter problems, which then cascade down and cause curve issues during times of active or rapid growth. Well, with the digestive testing, or I'm sorry, with the research that was published last year, what they showed is that they finally actually started to use a term called functional gastrointestinal disorders in scoliosis, meaning people who have scoliosis are far more significantly liable to report to you that they have these sort of almost kind of like subclinical in a certain sense, but just this collection of diffuse, nonspecific GI symptoms like irritable bowel syndrome, irregular bowel habits, sensitivities to different food groups or different food ingredients, and a lot of maldigestion issues like bloating, belching, etc. And of course, these are a lot of the things that can lay the groundwork for causing neurotransmitter disruptions. And so the GI system is very frequently one of the things that we have to attack in scoliosis patients in order to fix their neurotransmitter status. And of course, there are a whole lot of ways to do that. But again, I think the best way to do that, in my opinion, is with lifestyle and dietary modifications or recommendations, and using nutrient therapies in a certain sense, kind of as a band-aid at the start to help them feel better, and more importantly, to help them function like they should to get their neurotransmitter status back to normal so that it doesn't impact the outcome of their exercise-based care. And so to that end, I think the main sort of talking point or educational point when communicating all of this with patients, and we see it online all the time, right? You go on a lot of social media stuff and, you try to write anything about these kinds of connections to a spinal curvature, and people who don't know anything from anything will say, well, how can taking vitamins cure scoliosis? And they can't. And that's not what we're saying. What we are saying is that if you aren't addressing these problems, which we believe and have good research-backed reason to believe, that these are the underlying reasons as to why a given patient's curve started, if we don't get rid of the reason as to why their curve started in the first place, it's not going to really matter what you do from a physical treatment perspective. The curve improvements that you obtain in that patient are doomed to not last. And I think, quite honestly, I think the epitome of this is even in cases of patients who go on to have spinal fusion surgery. Their spines are fused, and we all know what that looks like. And yet, over the course of time, their curves still worsen. And why do they worsen? I think the answer is pretty obvious. They never addressed the reasons as to why that curve existed in the first place. And those things don't just magically go away because they got a fusion surgery. And I tell a lot of adult patients that I consult with they'll ask me, they'll say, well, I'm an adult now, so how can checking neurotransmitters or hormones or doing all these functional medicine things, how is that going to have any benefit for me since I'm done growing? And the answer is quite simple. A hormone problem, a gastrointestinal problem, a genomic predisposition, a neurotransmitter imbalance, these things don't just magically go away because you became an adult. Digestive things continue to evolve and get worse and insidiously progress to the point where now that person wakes up and they're a 40-year-old and they can't eat anything because everything they eat bloats them up or makes them feel terrible, or they can't lose weight now. These are all underlying problems of the gastrointestinal system and downstream from that, neurotransmitter disruptions. Because, of course, we talk about things like mood as adults, mood and stress adaptation and satiety. All of these things are neurotransmitter based. And so all of the other non-spinal symptoms that we see in scoliosis, whether that be anxiety or digestive issues or irregular periods, or I'm not able to stay asleep at nighttime, or maybe I can fall asleep, or I can stay asleep, but I have trouble falling asleep initially. These are all things that are explainable by neurotransmitter disruptions of various types. And if you don't fix those, not only, actually, I would go above and beyond to say we need to fix those, because at the end of the day, and again, this is sort of a tongue-in-cheek way of saying it, but it's not a curved spine floating into your office for care. That curved spine is attached to a patient who has everyday symptoms. That patient as a whole needs help. And everything about them needs to be helped if you want to improve that curve. Now, you might look at it this way, and very often I do, is I know if I'm helping their anxiety, I'm helping their digestion, I'm helping their mood, I'm helping them adapt to stress easier, then I know that I'm having a positive impact on their neurotransmitter status from whatever it is that we're doing in that regard treatment-wise, so that I'm more comfortable and I have a pretty good handle on the fact that when I do follow-up exercise plans with this patient, or they're here for follow-up, therapy options, whatever that looks like, even if they're just doing rigid bracing with me in my office, nothing is ever done by itself. There's not a single physical treatment in existence, in my opinion. And again, I don't care what flag you fly at your respective office. If you are only doing physical treatment for your patient, that treatment will inevitably fail at some point in time. It just will, because you never address the reason as to why that curve is there in the first place. And so at some point, when the patient gets out of the habit of following your exercise recommendations, whatever those are, the curve is now just going to be on the march back to what it was at baseline, or worse, because you never got rid of the underlying motivations or reasons, I suppose. With testing, the nice thing about the testing is that it's a panel. So you're talking about, looking at 11 different neurotransmitters, the more common ones. And among those, for example, if you go back to the data that I shared earlier, and like I said, if anybody wants access to this research, and I'll happily give you access to different PowerPoints for my company, Back Genius, that teaches all of this to people. But the idea is you get all of that information with one test. And that test provides you with very, very actionable information. And because of the way the test is laid out, the test also gives you insight as to, so going back to the lumber and the construction worker house analogy, the way that test report comes back is it gives you a little bit of a window into determining whether or not, okay, if I don't have enough serotonin, is it because I'm lacking the construction workers, or because I'm lacking the lumber, or both? And I'm very likely to get that answer from that same test. So the test not only helps me to identify the problem, it also gives me very actionable information in a way to sense that I can now implement a treatment plan that is very individualized to that patient based on their result. And I know, more importantly, where to intervene. Because I don't want to just give everybody everything, because ultimately they're going to waste some money doing that. And eventually, if you give somebody too much of some of the neurohormone precursors or neurotransmitter precursors, again, in time, you might provide them with a short-term benefit, but in exchange for a longer-term issue. So the testing is very, very vital into managing these aspects of scoliosis patients, because it absolutely reinforces the care that you're providing. As another example with serotonin, again, being that this is for Clear Institute, this would be very germane for this discussion. But serotonin is also, in concert with progesterone, are the two chief brain chemicals that are responsible for maintaining what we call central pattern generators. Those go by different names too. You could call them a motor engram, postural muscle memory, whatever you want to call it, but they are the automatic central nervous system body schema internal map of what my postural control is supposed to look like. Well, if I want to change somebody who has scoliosis, I want to change what their postural torso muscular coordination looks like. I have to be able to give the brain a different representation of what normal should be. And equally as importantly, if I don't have enough serotonin on board, it makes it harder for the brain to commit those repetitive postural exercise tasks and switching that over into long-term muscle memory or long-term changes in those central pattern generators. So again, if you're only doing therapy and they happen to be low in serotonin, guess what? Your therapy is not going to work. And unfortunately, I've learned too many times through School of Hard Knocks that that's just the truth. And it's great to do an x-ray at the end of their therapy or even 6 months later. But really what the biggest concern should be, okay, if I'm treating a patient for, say, in my office, on average, it's about 3.5 years from diagnosis to end of growth or skeletal maturity. My goal is I want them to not only be better at 6 months or 3.5 years later at skeletal maturity, I want them to be better 2 years after which I've never seen them, which is, now they're 16, 18, 20 years old and their curves are still improved. To me, that's now worth saying something. And if you're not getting to that point, you don't really know what kind of a benefit you're creating in the long term unless you address the patient in totality.
I think we should wrap it up now because I want to have a few minutes for questions.
Sure.
Yeah, so I mean, take a minute or two to finalize if you need to, but
No, I'm good. I'm good.
make sure
If
there's
anybody
time
has
for people to
questions,
ask
fire
some
away.
questions. Okay, I have a couple of questions. One
Okay.
is, are the uh, are the enzyme evaluations in the same panel as the neurotransmitters?
Well, the enzymes themselves aren't. But what happens is, so even among all of the neurotransmitters in the panel, the neurotransmitters themselves are just as much the lumber sometimes as they are the house. So if
Okay.
I'm looking at a neurotransmitter panel and one neurotransmitter is low, but another one is high, if the one that's high is normally supposed to convert into the one downstream, then I know I have an enzyme problem. So it's just a matter of knowing what's the enzyme responsible for that conversion.
Okay, understood. Understood. Um, Good. I want to give anybody else an opportunity to ask any questions. I don't want to hog these last few minutes. So anybody that has a question, please unmute yourself and speak up. Heather, can everybody unmute themselves? Or maybe put your hand up if you have, and Heather can unmute you. Okay. Yeah,
I have a
Blessing, go ahead.
question. Yes, thank you for the presentation. Since you
Sure.
talked about serotonin and progesterone being connected, do you also do hormonal testing at the same time as you test for the neurotransmitters?
I do. In fact, the lab that we use will test both at the same time on the same panel or on
All
the same
righty.
test kit, excuse me.
Okay, okay. Just one more. In terms of toxicity levels, have you found any toxins that could be connected to disrupt the serotonin and the progesterone that you also test for?
Yes. Now, for purposes of our discussion, yes, but that's a very big
Okay.
rabbit hole in and of itself. But yes, because quite frankly, when you talk about gut disruptions in particular, we have a lot of things in our everyday toxic soup of an environment we live in that are end up in our food supply, and as a result, cause disruptions in the gut. And those gut disruptions cause chronic inflammatory change, which affects microvilli length, which affects different nutrient absorption, which then causes the neurotransmitter issue. So, in short, yes.
Okay. Thank you.
Yeah.
Okay, anybody else have any questions that they would like to direct to Dr. Morningstar? I have another question, which is in the study, the first paper that you showed, where you talked about the people that were doing the supplements were getting a better long-term result than the people that weren't. It seems to
Sure.
me that like how did you deal with the confounding factor that the people that are doing the supplements are most likely much more highly motivated? You know, like they spent the money to buy the supplements. They bothered every day to take those pills. So they seem to me like they would be more likely to be very thorough in doing their home program as well. Did you deal with that as a confounder?
We did. So, and when you get in the paper, you'll see it too. I can send it to you. But what we did is we included people who, at least in my office, I don't know about how other offices do it, but our patients, we make them fill out a compliance scale. And so what we did is we controlled for both groups having an equal self-rated amount of compliance as to into an effort to minimize that. Now, can you ever eliminate that? Admittedly, no, you can't. Because it's not like wearing a thermoplastic button on a hard brace or something to get a truly objective gauge of compliance. But at least there was some level to try to minimize it to some degree.
Right. Okay. Understood. Okay, so I guess we'll wrap it up there. I really, really appreciate this talk. I personally really appreciate it because I have a degree in Chinese medicine and I use Chinese medicine in my practice. And it gives me what you've just spoken about really gives me a fuller understanding about what the pathways are and how I'm affecting these kids. Unfortunately, I find a lot of the kids won't take the supplements. So I would also like to, yeah, at some point, I'd like to hear further how you motivate people to do this. I guess one thing is giving them a more complete understanding about why it's so important to do it. I
Sure.
really don't do that. So I found it very, very interesting. I did take the class, and listening to you speak makes me want to go ahead and take it again. So maybe just for a second, maybe just talk about that. You have this online training program and what's involved with that, because I think that our doctors would like to know about that.
Yeah, sure, sure. So I run a company called Back Genius, and Back Genius within Back Genius we have what's called the Scoliosis Align program, and Align is an acronym that stands for Advanced Laboratory Integration of Genomics and Neurohormones. And essentially what it is it's a 9-course system. It's going to be available through Back Genius in January, and it will be available for CME credit. So what we have is in Back Genius, we have people from all walks of life, whether that be we have PTs, we have chiros from Clear, Scully Smart, Spine Core, all kinds. People who are just doing CBP, and what it is it gives chiropractors and PTs the ability to have every single possible tool at their disposal. Because I'm not really interested in what flag somebody flies. I'm mostly interested that every doctor out there doing the stuff we're doing is absolutely the best at what they're doing because they're offering the most comprehensive management arsenal to every patient they see.
Beautiful. Well, thank you again. Thank you very much. I really appreciate that. You know, one of my goals was to have all the different chiropractors that work in the field of scoliosis to come and work together. I feel like this split in our profession where this one won't talk to that one and that one won't talk to the other one. I feel like it's just such nonsense. And I really, when I reached out to you, I wasn't really holding my breath. I thought, like maybe he won't want to do it. But I really appreciate that you give us your time. And Dr. Morningstar was not paid for this. He's doing this just out of the love of the profession and the love of knowledge. And I want to acknowledge that. I want to give you gratitude. Thank you so much for giving us your time. It was really, really interesting.
Sure. Thank you, sir. I appreciate you having me.
Thank you, Mark.
Yeah. Hey, guys.
Hey.
Okay.
Take care.